We are presenting the second day of Track 2024 today with our oral presentation. We have 6 participants and we are happy to welcome you all here, and we are happy to welcome our judges of today, Dr. Padma, Professor of Medicine, Balaji Medical College, Dr. Subbaiah sir and Dr. Vengo sir. All three of us are here and they will brief you about the rules today, and then we will go with the presentation.
Good morning, one and all. I am Professor Dr. Subbaiah, Professor of Endocrinology and Head of Diabetology, Madurai Medical College. Today, for this oral presentation, 6 persons have been selected, and 10 minutes have been allotted to each one of you. And your presentation will be, give clarity at the same time. The statistics and final what is the message that at the end you want to deliver. That also you can include in the your conclusion. Okay.
Good morning. I am Dr. Vengo. I head the Department of Diabetes, Coimbatore Medical College Hospital. So, welcome you all for today's oral presentation. All the best.
So, I'm Professor V. Padma, Professor of Medicine, Balaji Medical College. So, I think we can start the presentations. The guidelines are clear. So, we'll call Dr. Josephine Antony Ammal.
All of you, glad to have this opportunity in presenting this rare case. I am Dr. Josephine, currently practicing in Nagarkoil as consultant and medical superintendent in a private hospital. I want to present a case that I came across with a patient having diabetes with a symmetrical peripheral gangrene. So this is the agenda that I will be going through. So I want to first of all tell you the symmetrical peripheral gangrene was first coined by Fishberg in 1938. It was found in patients with cardiac failure. As long run, they also found in multiple cardiac issues with the patients, and later it was found with sepsis patient also. First of all, we need to understand what is the definition of symmetrical peripheral gangrene. It is the bilateral gangrene found in the peripheral, specifically in the absence of major vascular occlusive disease. So I report a case here, patient having 67-year-old male patient having loose stools, 5 to 6 episodes with vomiting, came with the left upper limb swelling, blebs, fever, and pain for 24 hours. He also had decreased urine output for more than 24 hours. Past history having plaque psoriasis, having treatment for 5 years, but for 1.5 years he was on steroids. And he also found to have diabetes for since 6 months on metformin treatment alone. And that was the first picture that he had. And patient on day 1 admission, his vitals were, BP was less than 70 systolic, pulse rate was 130, SpO2 was 75%, ABG showed metabolic acidosis, blood culture and swab culture was sent, ECG showed sinus tachycardia, chest X-ray was with mild pleural effusion. So day 1 admission, if you see the blood parameters, total counts of 24,000 and creatinine was 3.2 and AST ALT was elevated and sugar was more or less in control, suspecting to have sepsis. This is the ABG report. So the diagnosis, I came to a conclusion, septic shock with disseminated intravascular coagulation, secondary to necrotizing fasciitis. So treatment started with, for vitals, vasopressor, noradrenaline and dopamine was started, oxygen supply with NIV intermittently, antibiotics empirically started, meropenem and fluconazole. Others like surgery opinion was taken. He advised for, first of all, to stabilize the patient for plan for debridement. DVT stocking was applied for left, both lower limb. Heparin was started. On day 4, if you see, counts were more or less the same. Creatinine was same. Moderately better, but CRP little bit down, but ABG stabilized, procalcitonin was very high, and blood culture, urine culture came as no growth, but wound culture, however, showed E. coli. So echo was done prior to plan of surgery. EF was 45% and global hypokinesia was seen. Since in spite of intermittently with the persistent low vitals, still took a risk to take him for the surgery. This was his picture on day 4. First debridement was done. And post-op, I was called by surgeon to OT saying that saturation patient was continuously having low from the time shifted from ICU. So I rushed to OT, saw the patient, and I saw his extremities were cold, clammy, but patient was GCS was 15/15. So I just told them, shift back the patient to ICU, I will take care of him. So in day 4 to day 9, if you see, his vitals were more or less was stabilized, and his discoloration gradually started developing bilateral upper limb and lower limb. And according to wound culture, we had continued meropenem and colistin. This was his lower limb picture. And Doppler, because of the picture, got frightened whether it is any he is developing any microthrombi or macrovascular thrombi. So got done all 4 limbs, the Doppler, which was normal. ANA also was done, which was weakly positive. So suspected what is the etiology, whether it is secondary to infection or any other cause. On day 5, I was called by a duty doctor in the early morning, 7 o'clock, saying that low sugar constantly. I gave 325D, still, despite of that, it is only less than 40%. So I told them, send the value to lab. It was 375. So I understood it is something wrong with the periphery in checking the blood. So continued the medication. So this all seeing, I suspected DIC because he had all picture of infection, thrombocytopenia was there, hematuria was there intermittently, microthrombi, macrothrombi, all suspecting was there. Again, I went through reading lot of articles and found that vasopressor can also cause this kind of picture. So I have been giving this patient for 3 days, vasopressor, dopamine and noradrenaline. So on day 9, this was his hand. So I went through and read about pathophysiology of SPG. So that was showing specifically of triggers of like DIC can cause, and risk factors like hypotension, vasopressor can cause to symmetrical peripheral gangrene. So this was the day 9, his hand on the left upper limb, you can see. And this is the second day, second debridement was done on day 9. And if you see his blood parameters of day 1 to day 10, you can see the difference from the total counts of 24,000 to 8,000 he has come. But however, thrombocytopenia is persisting and creatinine was almost coming to normal. CRP also was coming down. So this is the picture on day 14. We had put him on vacuum dressing and planned for discharge him home. And blood parameters, if you see on day 14, before sending him, almost normalized. So on day 26, patient comes back for the hospital saying that following the vacuum dressing removal, he had a lot of blood loss and it was 4.6 HP. So we transfused 2 units and took him for the skin graft and the amputation of the right upper limb. So this is the picture. And if you see SPG progression, what I went through is, you can see exactly how my patient went through. Day 4, they develop, and by day 10, they almost come to complete gangrene. This is the blood parameters of day 33, patient almost normalized. And DIC, vasopressor, infection, diabetes, all this alone itself can cause symmetrical peripheral gangrene. This is what I learned from this patient. So we need to focus on patient, just not one area. We need to focus on whatever the patient have, like sepsis, diabetes, DIC, all we need to look into. So I got into this picture because of vasopressor being given for 72 hours continuously with the dopamine and noradrenaline high infusion. DIC, because of high antibiotic we had given, seeing the picture, and diabetes was under control. However, it was intermittently that hypoglycemia got shock. And this is this other similar study that I have found in similar to my patient who had it. So learning points here I want to tell all of us is, we come across the patient almost day-to-day life with the sepsis and decreased urine output, who needs dialysis, all that. But we need to always get through touching the patient, feeling the patient. However, artificial intelligence can come, and however we can go in higher level, always the clinical, touching the patient, feeling the patient, and counseling the relatives and the patient matters a lot for convincing the patient for further treatment. So the summary and the learning point is this. So we can always decrease the mortality and morbidity. We can, with minimum morbidity, we can allow the patient to live. So this is the reference. Thank you. Thank you for this opportunity.
Good, nice presentation. It was a different case. All I need to know is, what are the other investigations you have done to rule out the common causes of ischemia? Something like connective tissue disorder, it's also perfectly possible in this case.
Yeah, ANA
except
was,
for ANA, what did you do?
we sent the full ANA profile. It was all negative.
What was the
But
CRP?
the patient, when CRP was, I had shown, first it was on 172, then followed by gradually it had come down to 32. On day 33, it was almost came to 5.
regarding your presentation, it was very nice. But other thing is, I want to congratulate you because the patient has been saved from this RDL, a very multi-system disease. One thing is, you have told E. coli. What was the sensitivity pattern of that organism?
It was actually sensitive to very few drugs, colistin, meropenem, and tazobactam. So because of the patient having CKD, he was not in CKD, AKI. So I wanted to choose the better one. So first of all, we had started on meropenem, so we continued with meropenem. As on day 4, as I showed the picture worsening, the necrotizing fasciitis was worsening. So because of that, I started even colistin.
Okay. This type of picture is quite common. That is, what we can say is, we can use the word not uncommon instead of saying common, not uncommon. We come across in Madurai also, DIC, especially DIC, taking the septic emboli from the primary focus to all the periphery. Probably the kidney injury also may be a septic kidney injury, full-blown septicemia. Yes.
I found this case interesting because symmetrical peripheral gangrenis I had seen first time, and I was wondering what is it. I went
thing
through.
is, it is a new terminology.
Yeah.
That's all.
So I went
but
through lot of
otherwise, this is coming under septic DIC.
Yes. But
Anyway, it is nice that you brought it to the forum.
because when I found this patient, all 4 limbs developing for me, first time in my MD I had not seen, in my MBBS time I have not seen. So I was like wondering what is it. I was going through a lot of articles to read and save the patient because the relatives had come from rural place and they were depending on me completely, and they didn't want to go to any higher hospital. So I need to really do my best for this patient.
That's why I initially said I congratulated you.
Thank you, sir.
Because you have taken holistic care. That is what expected out of an internist.
Because when we are in medical college, we have always professor support and consultant, but when we are all alone, that's really matters a lot.
Yeah, good work, Ma.
Thank you.
So we'll call Krishna Prasad.
Thank you.
Very good morning to one and all present here. I am Krishna Prasad from Department of Biotechnology, SRM University. I am a PhD student. So today I am here to present my research work titled Effect of canagliflozin on the crosstalk between between endoplasmic reticulum stress and oxidative stress in diabetic nephropathy. So, diabetic nephropathy is a common complication of type 2 diabetes, and the study has focused on mainly on diabetic nephropathy, and it has revealed that more than 50% of patients that develop type 2 diabetes have been developed diabetic nephropathy, and in this there is a particular stress factor known as endoplasmic reticulum stress. So endoplasmic reticulum stress is nothing other than imbalance between protein loading efficiency of endoplasmic reticulum, which is an organelle found in all the cells, and the crosstalk between oxidative stress and endoplasmic reticulum stress is revealed here. So oxidative stress is another stress factor that is main role player in all the cells. So this oxidative stress, it involves the generation of reactive oxygen species and superoxides, which will combat and make the cell apoptosis. So there are mainly 2 role players which manage the crosstalk between endoplasmic reticulum and oxidative stress, which happens in mitochondria. So these are endoplasmic reticulum 1 alpha, which is commonly known as ERO1, and protein disulfide isomerase, which is known as PDI. So our focus is targeting a major transcription factor, which is called as NRF2, which is an antioxidant defense enzyme cascade, which will target all the oxidative stress and reactive oxygen species inside the cell, and this will cause antioxidant defense, thereby protecting cell. So in this study, we have particularly taken SGLT2 inhibitor, which is canagliflozin, to reveal the crosstalk between ER stress and oxidative stress, and thereby how it manages the cell protein loading. So our hypothesis for this study is canagliflozin attenuates the progression of diabetic nephropathy by modulating crosstalk between oxidative stress and ER stress through the activation of NRF2 under a hyperglycemic environment, thereby preserving renal function. So our objectives are to decipher the role of canagliflozin in regulating ER stress and oxidative stress in diabetic nephropathy patients, and to explore the molecular mechanism of canagliflozin in regulating ER and oxidative stress in monocytes, and to investigate the role of NRF2, which gets activated during progression of DN, and how it is affecting in monocytes also. So our methodology involves a clinical study where we collected blood samples from different study groups, and we have collected serum from these blood samples and thereby gone for clinical parameters. And simultaneously, we have isolated PBMCs from the samples, and we have gone for RNA isolation and quantitative real-time PCR. So these are our exclusion and inclusion criteria. We have selected patients based on these criteria, and parallelly, we have also done a cellular study to validate the molecular mechanism and how the role players are there in cells. So for this, we have taken THP1 monocytes, which are main inflammatory markers. So these cells are divided into 4 groups, namely control, hyperglycemia, and drug alone treated group, and drug with hyperglycemia. So we have done Western blotting and quantitative real-time PCR for these groups also. So our results suggest that in patients treated with canagliflozin, there has been an increase in the EGFR level, which is in comparison in diabetic nephropathy patients. And we can also see that there is a decrease in biochemical parameters such as urea and creatinine, which are mainly increased in diabetic nephropathy patients. So to validate this, we have done quantitative real-time PCR for these PBMC study samples. So in this, we can see that the ER stress markers, which are namely GRP78, ATF6, and IRE1 alpha, these are mainly increased during ER stress. So we can see that in type 2 diabetes patients and diabetic nephropathy patients, which are highlighted in blue and red color, there has been a tremendous increase in these markers, which has been alleviated by canagliflozin treatment. So in parallel, we have also done the expression for oxidative stress markers, which are TXNIP and P22-FOX. Here also we follow the same trend, that is in canagliflozin treated patients, there has been a decrease in the oxidative stress marker, which suggests there is a change in the oxidative stress and the ER stress patterns inside these cells. So parallelly, we have done the expression of an antioxidant defense gene NRF2. Here also we can see that in diabetic nephropathy patients, there is a very significant decrease in the expression of NRF2, which is needed for antioxidant defense. This has been upregulated significantly by canagliflozin treatment in these patients. So to validate this in cellular model, we have replicated the same in THP1 monocytes. So in this, we can see that the ER stress markers are decreased in canagliflozin treated cells which are under hyperglycemia. This hyperglycemic environment mimics the patient who are under diabetic stress. So we have also revealed the crosstalk here. So the crosstalk markers, namely PDA1A2 and ER1, are usually increased during ER stress and oxidative stress, as they play a role between these two stress factors. We can see that in canagliflozin treated cells which are under hyperglycemia, there is a decrease in these markers. So this figure at the last is a representation of what is happening. So when there is when there is increase in ER stress, we can see that the ER stress markers will get increased, and then these markers are nullified by the treatment of canagliflozin. So to validate this in oxidative stress model, we have seen the mechanism of oxidative stress markers. Here also we can see that there is a decrease in the expression of oxidative stress markers upon treatment of canagliflozin. So we have also validated this in Western blot. The first two blots represent AKT and NRF2, which are antioxidant defense enzymes, and the next two are NQ and H1, which are downstream targets of NRF2, which are needed for the expression of of antioxidant genes. So the final one is GRP78, which is one ER stress marker. When there is increase in the expression of ER stress, the cell death happens. So we can see that upon treatment of canagliflozin, the marker decreases. The representative figure also suggests that upon treatment of canagliflozin, RO stress is inhibited, and this causes nullification of oxidative stress. So in conclusion, hyperglycemia generated ROS can promote the accumulation of unfolded proteins which are targeted in ER, and this causes cell apoptosis. So we are focusing on activating NRF2 by canagliflozin, which will get phosphorylated, and this can restore the cellular balance. So the representative figure also suggests that upon canagliflozin treatment, there is a phosphorylation of NRF2 which activates, and the ER stress and oxidative stress are nullified, and the crosstalk is also nullified. So I would like to acknowledge Dr. Vijay Vishnadhan, Head and Chief Diabetologist in MV Diabetes Hospital, for his support in this study. And I would also like to thank the study participants for providing samples for us.
Yeah, good study. What made you choose canagliflozin?
Ma'am, actually, upon other SGLT2 inhibitors, canagliflozin has been studied very basically. So this drug is not explored much, and we would like to see how its expression is mediating in endoplasmic reticulum and mitochondria also. So these are major organelles in all the cells. So we would like to see how its expression is mediated by this drug.
Very nice study.
Thank you, sir.
Tell us the baseline creatinine of these individuals, and after how much time exposure for canagliflozin
Sir,
you have taken the parameters.
actually, initially we have checked the levels for creatinine before the start of study. After 6 months of exposure of canagliflozin, we have generated these data. So we have selected patients in whose creatinine levels and urea levels are higher. So after the treatment of canagliflozin, we have seen this.
Any mean standard deviation during baseline and after canagliflozin? You have interpolated eGFR.
Yes.
Probably you have interpolated eGFR based on the EPI equation with
yes.
serum creatinine, I think so. So that is can you tell just eGFR from baseline to this percentage? I think you have given the relative percentage of improvement. Actual GFR, ML, that slide, yes. How far can you quantify the improvement of eGFR? Because it is interesting to note. From our south, because the kidney function has been told that it differs from population to population. I see this as a what I can say, eye-opening, or you are just treading in our population. Africans are known to have more. By virtue, genetically, they are more prone for kidney disease in the presence of diabetes. So I would like to have let you know from you the eGFR, what was the eGFR improvement in quantification terms after exposure to canagliflozin.
Sir, actually, after exposure to canagliflozin, we can see that eGFR levels are improved up to 120 mg.
Any mean data in the baseline and mean data after exposure to canagliflozin?
We have selected patients till whose levels are till 20 to 15. So they have improved up to 110 to 120. This much variation we can
Gross,
see.
you are telling a gross figure, 20. Okay, I think it is there in the file. You have to go through. Okay, anyway. Yes.
Did you use cystatin C in the calculation of eGFR?
We have used only creatinine for quantifying.
Did you use cystatin C also?
No, sir. Okay. Yes, sir. Following, we will check the liver parameters also for this. Yes.
The blood glucose levels or hyperglycemia itself can have a say on ER stress. Did you match the population for the HbA1c levels between the diabetic patients on treatment versus the diabetic patients on canagliflozin arm? Was it matched? I don't see any slide where the HbA1c levels were matched.
Actually, HbA1c level we have quantified. We have seen there is we have taken patients whose HbA1c levels are more than 10. So we have
No,
seen.
it was between 8 and 10.
Yes, for
So
different.
I can tell you, if the HbA1c is 8 and less, naturally the ER stress is going to be less.
Yes.
Versus the patient who has HbA1c 10 and plus.
Yes.
So what if canagliflozin arm had a HbA1c less when compared to the standard diabetic patients with nephropathy on standard treatment? So
sir,
was it matched?
Actually, according to literature, ER stress is like expressed in all the cells in all conditions. So when there is elevated stress only, this cell apoptosis and cell death happens.
Naturally, it is going to be high with more hyperglycemia.
Yes.
Yes. So it was not matched. Then how could you have come to a conclusion?
Sir, actually, we are just probing at the surface level here. So we don't know how ER stress is expressed in each patient samples. We are taking a basic study, and from that we are generating this.
What was the standard HbA1c of the patients who were on canagliflozin arm?
For patients who are on
What
canagliflozin,
was the mean HbA1c?
I think it's around 8.5 to 9.
So it is on the higher side. The other patients could have had in the other group somewhere more than that.
Type 2 diabetes.
The patients you had enrolled.
Yes, type 2 diabetes patients
It could be
might-
more.
Yes.
So without
Again-
matching that, you cannot conclude that the canagliflozin had a say on endoplasmic reticulum stress.
Again, was there any comparison between, see, the initial uptake of the patient was A1C 8 to 10. But during the course of 6 months, how many people had the A1C below 7? Was that an effect of reduction of A1C or was that an effect of canagliflozin? Was there any difference in the study?
Actually, ma'am, these patients who are enrolled under canagliflozin treatment group, they have taken only canagliflozin. We didn't.
No.
enroll
What
them
I'm asking is the benefit due to reduction of A1C and good control of sugar, or is it only due to canagliflozin? Has there been any differentiation made?
No, ma'am. I think it's based on canagliflozin treatment only.
Thank you
Okay,
very much.
thank you.
Definitely, this study is that is in a molecular based study. That way, I appreciate the study. Only thing is, still some more statistics could bring out somewhat more confounding, if confounding bias like Professor Vengo said, that could be isolated based on some more statistical work. And I think there is only canagliflozin arm alone was taken. Was there a comparative arm with other? Yes. So some statistical work will throw light on whether the glucose control, apart from glucose control, cana had a extra effect. Definitely that you can do it, no problem. Very good study, we appreciate.
Thank you.
Yeah, thank you.
Thank
so
you.
much.
Good morning, everyone. Good morning, respected judges. Myself, Dr. Naveen, Department of General Medicine, postgraduate. So, the title of the study is Factor Associated with Therapeutic Non-Compliance Among Type 2 Diabetes Mellitus Patient with Poor Glycemic Control. So, effective glycemic control is crucial in managing type 2 diabetes to prevent complication associated with the disease. Poor glycemic control remains a significant health challenge, primarily due to therapeutic non-compliance. It contributes to treatment failure, exacerbates the burden on both patient and healthcare providers. Over the past century, diabetic treatment has evolved significantly from a glucose-centered approach to incorporating organ protection strategies, advanced insulin delivery through smart pens, and cutting-edge monitoring technologies. Despite of this advancement, many individuals in rural areas continue to struggle with managing their blood glucose levels effectively. The study aims to explore the root cause of persistent challenges among diabetic patients in these regions. Primary objective to identify the therapeutic non-compliance among type 2 diabetes mellitus patient with poor glycemic control and to find out the factors associated. This is a hospital-based cross-sectional observation study. All participants with type 2 diabetes mellitus were selected with HbA1c of more than 8%, visiting the outpatient department, and they were admitted. The duration of the study was 6 months. After getting approval from the Institutional Research and Ethics Committee, the data were collected from 105 patients through face-to-face interviews and using an 8-item Moriskin's medication adherence scale and semi-structured questionnaire created to address the population needs that captured socio-demographic information, clinical characteristics, and patient lifestyle factors. So coming to the results, based on the socio-demographic details, the patient were selected a total of 105, in which the male patients are around 54 and female patients were 46. The age category, it was 58.5% in the 61 to 75 years of patients, and the overweight patients were around 42.8%. A majority, around 71.4% patients were diagnosed with diabetes for more than 5 years, and 61.5% had been on treatment over 5 years. Approximately 66% of the patients did not attend regular follow-up appointments, and 48% had developed diabetic complications. And most of the patients have retinopathy as a most complication. 45.7% of the patients reported lack of regular physical activity, and 51.4% did not adhere to dietary guidelines for diabetes management. And the education of the patient, around 30% of the patients had no formal education, and more than 40% of patients with primary education. So coming to the factors contributing, the patient-related factors, I would like to highlight some of the specific factors. The patient having economic problems to buy prescribed medications, which was seen around 54.6% of the patients. Lack of information about prescribed medications was seen in 57.7%. Unawareness of side effects of prescribed medications were seen in 49.3%. And patients not able to visit the physicians regularly for consultations, it was more than 50%. Patients not performing regular exercises and dietary advices were more than 50%. And some of the patients having habit of eating nighttime food after 10 p.m. And some of the patients told like they are feeling better with herbal medications, but these patients presented to the ER with FBS and PBS of more than 500, and their HbA1c was more than 10%. And some of the patients have experiencing sleep disturbances. So results, the predictors of poor glycemic control were assessed using multivariable logistic regression analysis, considering the factors such as age, sex, education level, income, diet adherence, alcohol consumption, comorbidities and duration. Dietary adherent, non-adherents had a even stronger association, and low income levels were linked with the increasing risk of poor glycemic control. To conclude, this study highlights a high prevalence of poor glycemic control among type 2 diabetes mellitus patients, significantly influenced by financial constraints, lack of regular follow-ups, inadequate physical activity, and poor dietary adherence. Implementing lifestyle modifications such as improving diet and increasing physical activity could enhance the glycemic control and prevent the progression of diabetic-related complications. There is an urgent need to offer personalized advice and support to the diabetic patients, especially those in underserved areas. Affordable medications, specialized support to the nearby PHCs, and leveraging medical institutes. There is more than 320 medical institutes, including private, and more than 300 government setups were in India. So we can go and help with them in the primary healthcare institutes, so providing them support, and policy change and implementations. I would like to thank my Dr. Girija ma'am, Professor and HOD of Department of General Medicine. Thank you. Thank you for the opportunity.
Thank you. Good presentation.
Thank you.
Can you go back to the study methodology slide? So this was a cross-sectional observational study.
Yes.
With that, you just can tell that the percentage of people who were out of control had the risk factors that you had proposed, right? Why did you not include a comparative arm wherein the control was good? Say if I tell you illiteracy is not the factor for a good control, how can you tell so?
Actually, the comparison is better with the patients, but here we thought of like the patients with HbA1c of more than 8% as a standard thing.
Either you should have had another group with HbA1c less than 7 or a good control group. So without having a comparative arm, you cannot come to any conclusions. Especially, this is a study where it is easily possible to, it can be done easily. You can enroll patients. So just observing a patient with high HbA1c and finding out the frequency of occurrence of the proposed risks that you think of cannot give a conclusion.
And regarding the study, along with the questionnaire, you added something like semi-structured questionnaire.
Yes.
What were the things which were added along with this scale?
Some of the questions were already included in Morrison's scale, and we
Okay, the
included-
next slide. Can you just put on the next slide? Next. Unawareness of side effects of prescribed medications were seen in. Do you think it is a factor contributing to non-adherence? Because I don't think this is a factor contributing to non-adherence.
Yes, ma'am.
See, unawareness of side effect is not going to tell whether the A1C is going to be high. Whether you are aware or unaware of the side effects, A1C high is because of a lot of other maybe economical problem, lack of information, those are all right. But unawareness of side effects, maybe patient would not be able to pick up the side effects, but not related to A1C. So I think the questionnaire also has to be a bit more validated, because without a validated questionnaire, I think the study becomes not proper.
I mean, these are all known facts.
Yes, sir.
These are known country has very poor control. With all,
Still,
what's the new thing you're telling us?
even it is a old fact, still in some of the areas it was lacking, sir. The root cause, it was lacking. In some of the rural areas, the patient were not aware about the exact situation. So we thought of like bringing them out.
Even in United States, the A1C less than 7 is only about 7%. How can you expect in India to improve? Because these facts are very well known for so many years that our patients have lack of education, motivation. Doctors spend very less time with the patients. We don't tell them how important is the exercise, how important is the food control, and then the discipline in life. I think, I don't think you have found out anything new out of this.
No, sir. It was a old thing, but we thought of creating more awareness with this.
Maybe that's
In
a-
our setup, most of the patient.
For want of time, just sir, anyway, you have presented this study. At that level, we appreciate you.
Thank
It needs some more fine tuning, and control arm would be more valuable. You should have done it, and also fine tuning of the questionnaire and all. This is a study which is mainly focusing on public health aspect of diabetes, which would help in forming policy formulation, for forming advocacy. So RSSDI being an advocacy group, just we already are aware of the financial and other implications why non-adherence to treatment is there. Anyway, you have also participated in that. At that level, I appreciate you.
Thank you, sir.
Best wishes. The next speaker, Shivashankari.
A very good morning to one and all present here. I am Dr. Shivashankari from MV Hospital for Diabetes, here to present on comprehensive intervention and its effect on favorable diabetic kidney disease outcomes. Dean for the study, compliance with the recommended intervention and regularity of follow-up are essential to prevent the development and the progression of chronic kidney disease among people with type 2 diabetes. The aim of this study was to assess the relationship between regularity of follow-up, recommended intervention, and its effect on CKD outcomes among people with type 2 diabetes. This is a prospective observational study where we had 216 participants included from January 2022 to June 2024 in a tertiary care center for diabetes. The participants were divided into two categories, where we had group 1 participants who had made regular visits, a minimum of 3 or more visits and with 2 HbA1c per year, and participants in group 2 were irregular with a minimum of 2 visits or less and with 1 HbA1c per year. All the participants in the diabetic kidney clinic received intensive individualized counseling and to adhere to the recommended medical and dietary advice and to visit the clinic regularly. In terms of the counseling that was given, we asked the patients to keep the blood sugar under control, we asked them to keep the HbA1c less than 7, and we asked them to keep the blood pressure under control as well as the LDL cholesterols. We motivated them to keep their BMI under control, to go for regular walking and exercises. Demographic, anthropometric, hemodynamic and biochemical as well as treatment details were recorded at baseline 2022 and at each follow-up visit in 2023 and 2024. The participants were classified into 4 stages based on KDIGO 2012. CKD stage 1 is low risk, CKD stage 2 is moderately increased risk, CKD stage 3 is high risk, and CKD stage 4 is extremely high risk. So as of the results is concerned, we had the median age and the duration of diabetes in the baseline in both the groups were similar. After 2 years of follow-up in group 1, that is the participants who were regular, there was a significant reduction in fasting. What was 157 in the baseline improved to 125. Postprandial glucose decreased from 230 to 174, and HbA1c, which was 8 in the baseline, became 7.3. In group 2, with the participants were irregular, there was significant increase in the fasting. 125 became 156, postprandial glucose from 193 became 218, and HbA1c increased from 7.1 to 8.4, which were all statistically significant. When we looked at the kidney parameters, the eGFR trends among the study groups, where participants were regular, the eGFR, there was a significant improvement in the eGFR from 65 to 70 to 75. And then there was a decrease or decline in the eGFR from 73 to 67 to 58 in the follow-up years. As of albuminuria is concerned, the participants who were regular, we had three categories of normoalbuminuria, microalbuminuria, and macroalbuminuria. We can see that the proportion of participants increased from 11.4% to 72.8% in group 1, where the participants were regular, and the microalbuminuria decreased from 83.3% to 27.2%, and the macroalbuminuria also decreased from 5.2 to 0. The vice versa was observed in the participants who were irregular. The normoalbuminuria decreased from 77.5 to 6.9, and microalbuminuria increased from 22.5 to 87.3, and there was appearance of macroalbuminuria in participants who were irregular. We can see the transition in the CKD stages where we have the proportion of participants across CKD stages in the group 1 that was regular. There was an improvement in the proportion of participants in CKD stage 1 from 11.4% to 66.7%. And there was a reduction in the proportion of participants in CKD stages 2 to 4. From 54.4, it became 27.2, and from 28.9, it became 6.1, and in group 4, from 5.3, it became 0. And all were statistically significant. Based on the comorbidities and anti-diabetic medications, we found that participants who were in the irregular group, that is, the participants had higher comorbidities like hypertension, dyslipidemia, and retinopathy, which were all significantly higher in the irregular group when compared to the participants who were regular. As of the anti-diabetic agents were concerned, we found out that majority of them were on insulin and oral hypoglycemic agents, and we tried to figure out which oral new anti-hypoglycemic agents made the difference. We found out that they were on SGLT2 inhibitors and DPP4 inhibitors, and we found that the participants who were on newer anti-diabetic medications like SGLT2 were significantly higher in the participants who were regular than the participants who were irregular. I would like to conclude by saying that our study findings highlight the favorable kidney outcomes and prevention of other diabetic complications among those who visited the clinic regularly. Thus, in real-world clinical settings, adherence to the treatment and medications as well as regular follow-up visits can prevent or delay the progression of diabetic kidney disease. I would like to express my sincere thanks and gratitude to Dr. Vijay Vishwanathan sir and Dr. Satyavani ma'am for their immense support and valuable guidance. Thank you for your attention.
Good presentation. What is the element of novelty in your study? This is absolutely known fact.
Yes.
Person who is going to be irregular will not necessarily adhere to the medicines also. So what are you trying to tell us that is new that we don't know?
We are trying to tell you that there is no studies which have actually inform people that this is statistically significant. And participants who are regular.
Enough studies.
Enough studies are there which
enough number of studies on this.
From the UKPDS, intensive control is definitely going to prevent or reduce complication. That is there from many old age. I don't think it's new. Anything?
In our center, we did not have any studies, so this is the first.
You're telling your center study.
Yes,
you want to highlight it. Okay.
So we wanted to find out the relationship between people who came regularly and people who did not.
Good, you have presented the study. Regarding whether it is prospective, I think it is mostly a retrospective. You have collected data, retrospective.
Yes, sir. We started in 2022 and we followed them up to 2024.
No. How come you know that they will become, that is, they will not come regularly? Group separation, you would have done at the end of the study only, isn't it? That means it is a retrospective study. Huh? So please don't, nomenclature should be changed. It is not prospective, because you are going from the back, that is from today to back, how they have been, whether regular or irregular for the clinic follow-up. Okay, that basic thing you please correct it.
Okay,
but otherwise, I am coming to your rescue. One of the judges was asking what was the novelty in this study. I find that the SGLT2 inhibitor and DPP4 inhibitor in Indian scenario is also equally better like that of the other study. Most of the studies are European studies and other US studies. Here also our kidneys also work favorably for the SGLT2 inhibitor. So I think that is one, to that end you have a study which is also vouching for that fact.
All your hypertensives on RAS blockade?
Yes, sir.
100%.
Yes, sir.
What was the standard of care for the?
How many you added finerenone in this group?
We excluded finerenone in this group, sir. We didn't. No, sir.
But I was astonished. You had a presentation. The macroalbuminuria became normal.
Yes, sir. We had very few percentage of population.
5.2.
Yes, sir.
Yeah, we will like to call upon the next speaker. Divya
We
Bhatt.
had very few proportion of participants in macroalbuminuria, sir. We are trying to increase the sample size and include more people with proteinuria to find the difference.
My topic is about comparison of short versus long duration healing time in diabetic foot ulcer. In a minute, I would like to give an overall outline about my study. So basically, either in any way, any foot ulcer is going to be healed either by medical intervention or surgical intervention. So we would like to know the thing matters is the duration of diabetes, duration of the healing time. So we would want to know, is there any difference between the healing time, the healing time which takes faster or delay, and if it is there a difference, we wanted to know what are the differences. The introduction: individuals with diabetic foot ulcer are at risk of amputation, and therefore the healing of diabetic foot ulcer is paramount importance. The diabetic foot ulcers could lead to a non-healing wound, and in delay in seeking treatment may lead to complications. High plantar pressures have been implicated in the development of diabetic foot ulcer in the presence of diabetic peripheral neuropathy. No longitudinal study has previously examined plantar pressures in individuals with diabetic foot ulcers. Our study objective is to compare clinical, biochemical, and comorbidities among people with short versus long duration healing time in diabetic foot ulcer. The study design was prospective cohort study with a sample size of 150 participants, and the study site was Tertiary Care Center for Diabetes in Chennai. The study duration was 3 years. We included the participants with a typical diabetic foot ulcer, which was formed by the pressure of their foot and ulcer formed on the plantar surface, with the follow-up of until wound healing. We had a variables of socio-demographic details, clinical profile, wound type, and date of onset of ulcer presentation were recorded. The ulcer was graded by Texas Wound Classification. Healing was defined as the epithelialization or any medical intervention.
Sorry for interrupting. May I request the audience to please maintain silence so as not to distract the speaker. Please carry on.
Thank you, sir. So, taking median time for healing duration, we divided the group into two: shorter duration and longer duration, with the above median healing time as shorter and below median healing time as longer. The results showed the socio-demographic details were almost similar in both the groups. The significant difference was in the referral group. So the time of onset of ulcer presentation, when they came here, the difference between those days were significant, and the foot were before the ulcer presentation. As soon as they were diabetic, they who had started to wear the customized offloading and who did not. This gave us a significant result. So with the medications, even though it was not significant, the higher percentage in the group 2, which is longer duration, were taking both insulin and OHA. Surprisingly, in the wound grade, the third grade was taking a shorter duration. 30% were overall third grade percentage were higher in group 1, which is a shorter duration, and lesser were there in group 2, which is a longer duration. The comorbidities difference: the CVD and PAD showed a significant difference. The other comorbidities were not significant. To conclude, Longer duration had a significant for PAD and CVD. Early referral was significantly high in shorter duration when compared to longer duration. Shorter healing duration was observed in grade 3 wounds. Our recommendation will be early diagnosis and early referral would promote the healing of diabetic foot ulcer faster. Long-term offloading is needed in people with diabetes to facilitate ulcer healing.
Good presentation. Like, what differentiated short term versus the long term duration?
The median time, sir.
What was that?
43.5. 43.5 days.
So anything over and above 43.5 was considered as a long duration ulcer, is it?
Yes, sir. Greater than 43.5
So
days.
what made you choose that 43.5?
Sir, I just went with the median time healing.
So say, for example, for me, even a wound that doesn't heal more than 2 weeks or 3 weeks, I'll call it a long duration ulcer.
Yes, sir.
Do we have any definition anywhere?
Sir, in plantar pressure, it takes 4 to 6 weeks to heal a ulcer.
Any standard definition for short duration ulcer versus long duration ulcer? There is no exact.
There is no exact.
So, the basic definition is out, right? And number 2, who treated? What were the treatment modalities?
Okay.
Were the the specialists who treated and everything standardized? So, if a competent person would have treated, it would have healed better versus a person who did not have the enough competency. So, was that standardized?
It was not about the same treatment, ma'am. No, we did not choose the participant as the same treatment. We just took a typical plantar pressure foot ulcer and we just observed their healing duration with whatever the treatment. Yes. No, ma'am. We wanted to just compare with no particular thing. So we just compared, ma'am. We did not do we did not define the group, but we only wanted to just compare whoever is coming to our clinic because we wanted to do it randomly.
Again.
Okay.
Your presentation, for want of time, just yes.
How many had a neuropathic ulcer? How many had ischemic ulcer? How many had a combined ulcer?
So in shorter duration, it's 69.1% had neuropathic and 30.9% had combination of ischemic.
They tend to heal faster, no, with offloading.
But it was not significant, sir. It's maybe the sample size, if I had.
Yeah, definitely.
That's what, because she couldn't answer it. That's what I wanted from her mouth, because she's the presenter.
Yeah, yes, ma'am. We did either by medical.
It's okay. I think it's time out. We'll call.
The presentation was, that is, you have brought forth the factors. Some more statistical work could have thrown light. Another thing is, since Sir is here and has intervened, I would like to know one surprising fact is grade 3 ulcers heal better. Yes. That as a thing, it needs some work. There is some confounding bias, I think so.
No, sir. Because I would like to justify it, sir. The grade 3 ulcer, it healed longer because medical attention and surgical attention were given to that particular group. Because grade 1 is not...
that means reconstructive work has been done in the grade 3. Yes, yes. That is the confounder, really. Okay.
It's okay. So I think we'll have the next presenter, Dr. Niveda. Thank you, ma'am.
Thank you, ma'am.
So good morning, one and all present here. Today my talk is about hypolipidemia may be the risk factor for pulmonary tuberculosis patient, and it is a retrospective observational study from the South India. So there is a growing evidence of connection suggesting that low lipid levels have a direct impact on several human ailments, with TB being one among them. So the lipid plays a vital role in the immune system for the macrophage to engulf the bacteria. The density of the cell membrane is maintained by the levels of the lipids and cholesterols in the human body, which have a beneficial effect on the tuberculosis. So here I would like to say that cholesterol is a cell membrane that is important for the cytotoxin function, and this activate the lymphocytes CD4, CD8, and which recruit the macrophage and release the molecules such as interferon and TNF, so which render their more efficient in killing Mycobacterium tuberculosis, and the inability of the macrophage to uptake Mycobacterium tuberculosis due to low cholesterol content of the cell membrane might constitute a key defect in the host defense system against tuberculosis. So the need for the study was, there is limited data available on the association of the lipid levels with tuberculosis and tuberculosis with the diabetes patient, and my aim of the study was to assess the lipid levels among the participant with TB and TB with the diabetes group in comparison with the control group. So in the study is a retrospective observational study where the patient was recruited from the TB units and UPHCs in the North Chennai, and the study the data is retrospectively retrieved from EDOTS cohort and Report India phase common protocol phase 2. Initially, we have, in the study, 92 participants were, based on the eligibility criteria, were recruited, and they were furtherly divided into two groups, the participants with TB and without TB. And we wanted to look for a sub-analysis, so we furtherly divided these two groups into control groups, patient without tuberculosis, only diabetes mellitus group, and in the positive cases, like with the participants with TB, it was furtherly divided into TB and TB with diabetes mellitus. And then we tried to analyze their lipid profiles. And the statistical analysis was done using SPSS version 29, and the independent t-test and ANOVA was performed in this study. So, in the results, when the mean age of both the groups were almost similar, but the p-value but we didn't have the significant p-value. But when you see that total cholesterol, HDL, LDL, and VLDL among these groups show a significant difference between these two groups. When you see the group 2 has lower, that is TB group had lower mean cholesterol level when compared to the group 1 without TB. And the BMI and triglycerides, we did not see any difference between the group. That is, the mean might be little lesser, but the p-value doesn't show any significance here. So in our sub-analysis, we tried to see, in that we found tuberculosis group had a lower lipid levels, that is 121 in the TB group and TB with diabetes mellitus group, whereas in HDL cholesterols were also low among both these, among these groups when compared to the control groups, and LDL level were also compared. So here the cutoff point which I've taken here is according to ADA recommendation, the cutoff point for the low lipid level is 120 below, and for LDL it would be below 50. So it is nearing, I mean, the borderline of the cutoff point, but it is low when compared to both the groups. So the conclusion would be the study finding highlighted there may be an association between hypolipidemia and tuberculosis, indicating that low lipid levels are the risk factor among the people with TB and tuberculosis with diabetes mellitus compared with the non-TB groups. And if you see it is not even included in the NTP guidelines. We do check for renal function test, liver function test, we do check for blood glucose levels, but still now the lipid profiles are not included in the NTP guidelines. So I strongly recommend the lipid profiles should be included in the NTP guidelines. And the lipid levels should be corrected while treating TB before response to the treatment for the proper immune function. So it can be given as a nutrient supplements like that. So, and in my study, I would recommend that this association needs to be confirmed further with a larger sample size. And I would like to take this opportunity to thank NIRT, National Institute for Research in Tuberculosis, and ICER department for running our samples, and Greater Chennai Corporation to permit and allow us to enroll the participants from the TB units and hospital.
Okay, thank you, thank you. Good presentation, but I just want to know what could be the pathogenesis of a low lipid level in tuberculosis, because tuberculosis patient would not have appetite, they might not be taking their diet. Is it related to malnutrition, or you really want to attribute it as, because you're clearly wanting to tell it as an etiology and you want it to be included in the guidelines. So what makes you tell that?
So I would recommend two things. I can put the hypothesis in a two way. It could be a predisposing factor also, and it since TB is a catabolic. Yes, I'll tell ma'am. So it is a predisposing factor, and also if you see TB, they are prevalent in the urbanly poor population, where they have low lipid levels. Urbanly poor population, malnourished. So
malnourishment with tuberculosis can be linked. Low lipid with tuberculosis, how are you linking? What is the pathogenesis? I just want to know that.
So the lipid acts as a protective mechanism against the bacteria, right? So we need some of the...
Is it?
See, such a very small sample, you cannot tell such a big ramification hypothesis. See, this is nowhere else, this hypolipidemia connection with tuberculosis. Hypolipidemia is a thing which is basically linked to the liver pathologies. Hypolipidemia, as Madam has already pointed out, definitely it is because of a corollary of malnutrition, tuberculosis patients having alcohol. So just hold on, don't intervene. And if you want to say that this could be a risk factor, in the community, you have to check the lipid levels and see when they acquire tuberculosis, whether they acquire more, prevalence is more, like that. And as well as also, after curing of tuberculosis, say after 2 years, you have to check the lipid levels. What is that? Still they are having low lipid than the general population. So this is a thing where you are totally carried to the confounder. This is definitely we are of the opinion.
So that is why I recommend while treating tuberculosis, lipid profile should be checked before treating tuberculosis. That will help in the proper.
No, that's all. Why? I want to answer for
disease
why.
Burden of inflammation burden will be higher in
Do you
these
mean to
cases
tell lipid is low means inflammation is more? I think it's the vice versa.
No, I can answer this. Like, there is an association between hypolipidemia and tuberculosis.
Yes, sir.
Accepted. There has been a very big study in South Korea, somewhere enrolling around 50 to 80,000. It is just an association. But you cannot imply hypolipidemia to cause or be more susceptible to tuberculosis bacteria. Because as per your study, it is just a cross-sectional study, right?
Retrospective observational
Yes.
study.
So, like, you took the number of patients in the general population versus number of patients who had tuberculosis and found the lipid levels, isn't it? It's as simple as that. So there can be an association, but you cannot imply this low lipid levels to tuberculosis. With such a small sample size, you cannot go to the level of recommending this to NTEP guidelines, number one. And number two, family history. Family history is one of the major confounding factor for high dyslipidemia.
Yes, sir.
So, did you have any questionnaire? No. So, the choosing the study population itself, it was flawed. Okay? And number two, ATT can have a say on lipid levels. So what was the ATT that was given for the tuberculosis patients you had chosen?
So
was it
this
the standard
was,
treatment protocol?
This was the lipid profile which was taken at the baseline before starting ATT.
So only just smear positive
that's why
tuberculosis.
I
So
said
as
it is
madam
lipid.
told, before the patient recovers, the patient could be malnourished. So naturally lipids are going to be low. How can you imply that low lipids can be a predisposer for TB?
Your lipid association guidelines keep telling that having the LDL lower, the better. They want a recommendation of below 50 for diabetic patients. And once if we tell that low lipid is associated with tuberculosis risk, and it's really going to be very difficult for us to manage.
Thank you. Thank you.
Team, for the postgraduates present here, the quiz prelims will be held at 12 o'clock in the Vahini Hall. It's right next to where the poster presentation was conducted yesterday. Okay. So we'll come to the conclusion of the oral presentation. The prizes will be announced today evening in the valedictory function. I request all the participants to wait. All the participants will receive a memento and an e-certificate during the valedictory function. They will receive a memento, and the first prize will be a medal with a cash prize of 5,000, and second prize is 4,000, and third prize is 3,000. So I request the judges to come out to the stage for their final comment.
So this was 6 participants. All of them did their job more or less well. And one first participant, one thing which is a case presentation. Others are study presentation. And real research, that is molecular based study, one Dr. Krishna Prasad presented. And other person, Naveen. 1 minute, we will close this session.
Generally, when you present to this audience, we prefer the actual researchers rather than case reports.
Yes. Then regarding Naveen presented, that is non-complaint, public health based, that is epidemiological work. But it is within the hospital, so hospital based epidemiology. Shiva Shankari presented a case of, that is diabetic kidney disease, that is multi-factor intervention regarding that. Again, it is an observational thing. And Divya Bharati presented that is again observational work on diabetic foot ulcer. And hypolipidemia is that is one thing, but it has a gross concern regarding the confounding bias has to be ruled out. But anyway, the presenter presented that concept. Okay. With this, we summarize this session, and our conclusions would be handed over to the organizers. And thank you one and all for this opportunity.
Great appreciations to all the participants. All the best. Thank you so much.
Thank you.
All the best to the participants. Actually, PGs have to be encouraged more and more to present more original research work. I think there was one original research work. Others have attempted to do. Let people keep doing more and more work.
Request the judges to be on stage for a moment. I request Vijay Vishwanath sir to honor the judges with the mementos. Request Vijay Vishwanath sir to give the memento to Dr. Padma ma'am. Request sir to honor Dr. Subbaiah sir. And also to Dr. Vengo Jayaprasad sir.